This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti o Waitangi partners.
Welcome to Talking O&G, the podcast from the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, or RANZCOG. In each episode, we take a closer look at RANZCOG guidelines and research from the Australian and New Zealand Journal of Obstetrics and Gynaecology. But we're not just summarising. We're speaking with experts to unpack evidence-based research, highlight key takeaways, and explore what this means for real-world care across Australia and Aotearoa, New Zealand. I'm Associate Professor Scott White. I'm an obstetrician and maternal fetal medicine specialist based in Perth. I'm the editor of the Australian and New Zealand Journal of Obstetrics and Gynaecology, and I'm your host for today. In today's episode, the first of the season, we're focusing on RANZCOG's new guideline on miscarriage, recurrent miscarriage and ectopic pregnancy. We'll be joined by Dr. Kasia Siwicki, Dr. Nicole Liesis, two expert clinicians who have helped develop the guidelines we'll be discussing, and we're also joined by the co-founder of the Early Pregnancy Loss Coalition, Izzy Kashia. We'll be back in a moment, but first, a quick message from RANZCOG.
The RANZCOG annual scientific meeting is back for 2025, and this year we're bringing it to Adelaide. Heather, what do you have in store for us?
Thanks, Nisha. We're really looking forward to hosting the RANZCOG ASM, and from the 18th to the 22nd of October, we would like everyone to join us at the Adelaide Convention and Exhibition Centre for 5 inspiring days of learning, insight and also real connection. This year's theme, From Conception to Curtain Call, reflects the full journey of women's health, with sessions covering fertility and pregnancy to menopause and beyond. You'll hear from the global leaders in the field, including Dr. Matthew Leonardi, Dr. Laura McGee and Dr. Linda Brubaker. Plus, we've got some excellent hands-on workshops planned, and don't miss the gala dinner. It's going to be a chance to network, dress up and unwind with colleagues. You can earn 23 CPD hours for attending the full program.
That sounds fabulous. I can't wait to join you in Adelaide.
For anyone who is wanting to join us, visit ranzcogasm.com.au and come visit us in Adelaide.
Looking forward to seeing you all there.
Today, we'll be joined by...
I'm Dr. Kasia Siwicki. I'm a staff specialist in obstetrics and gynaecology at Alice Springs Hospital in the Northern Territory. I was the chair of the Guideline Development Group for this miscarriage, recurrent miscarriage and ectopic pregnancy guideline.
I'm Dr. Nicole Liesis, and I'm an emergency physician, and I was also a member of the Miscarriage Guideline Development Group. I earned my RANZCOG diploma nearly 30 years ago, and currently practice emergency medicine both virtually and in person in rural Western Australia, where distances are vast and women's health services are limited. I bring the perspective of a frontline clinician, often speaking with women at their very first point of contact when early pregnancy complications arise.
Hi, I'm Izzy Kashia. I am a journalist and the author of the book Hard to Bear, Investigating the Science and Silence of Miscarriage. I had 7 losses. I have 2 living children, and I also co-founded the Early Pregnancy Loss Coalition.
Thanks, Izzy Nicole Kashia. Welcome. It's great to have such an expert panel here to join us. Izzy, I might start with you. I know your advocacy in this space was motivated by your personal experiences. Can you explain to our listeners what drives you to want to make a difference for those experiencing miscarriage?
So as I was going through my losses, being a writer and a journalist, I was constantly asked to write about miscarriage or my experiences or whatever, and I just didn't want to do it. I wanted to wait until my journey was complete before I really looked into some of these issues. So after my second living child was born, I started looking for answers to these questions that I had, like how can I be pro-choice but I'm mourning a loss at 6 weeks? Like, how does this work? Why is it like this? And also, I didn't understand how in the support groups that I was in, I could see the same complaints over and over, the same issues that people were having when seeking care. So there was clearly commonality, not just among patients and in Australia, but among patients in Australia and overseas in other countries. So I had all these burning questions, and being someone that likes answers, when I have a question, I went off and just started reading, and I just realised that there were more questions than there were answers. But the answers that I could find were fascinating, like really interesting. Everything from medical studies that just, shed light on things that had really never been, put out there, the results, they weren't influencing practice, medical practice, all the way through to how history and culture have combined to create silences and cultural issues within language and things like that. So unfortunately for me, I thought it would be an article. It ended up being a book, which is my book. So 120,000 words later, I produced this book. And I think the motivation was really like, it just shouldn't be like this. It shouldn't be so easy for me to find people who've had terrible experiences in seeking care, whether that care is psychosocial, whether it's from their peers, whether it's from their clinicians. Just the whole experience was just compounding the grief. And it was such a lack of understanding, both socially and in the medical system. So I set out to write my book swearing to myself that if my daughter or my son ever experienced what I went through, that they would have a better road than what I had. And then I decided with two very good friends of mine, Dr. Jade Bellardi and Melanie Keep, co-founded the Early Pregnancy Loss Coalition, which is a group of, we're about 20 organisations now working across the miscarriage space in order to create a single voice for change in all different areas of care, whether it's, education programs in community or, doctors or ultrasonologists or whatever. We want to see real improvements and developments in the space. So, and we were responsible for getting the federal budget package for miscarriage, which was almost $10 million. It was the first ever budget spend or federal budget package dedicated solely to miscarriage.
Wow.
So that, we're having lots of wins, and we were so pleased to work with and support RANZCOG on developing these guidelines. It's just a huge achievement from everyone involved.
Yeah, thanks, Izzy. And there's now, as you mentioned, clearly a national momentum and funding in this space. So as the co-founder of the Early Pregnancy Loss Coalition, are you hopeful about the direction that things are heading?
I think it's really easy to feel overwhelmed because of the nature of the issues and how many different things that we have to do. And I'm very much a doer. So I'm like, I need to slow down and be like, we can't do everything all at once. We have to pick our battles and pick the things, from the low-hanging fruit to the, very long-term structural changes. But absolutely, I am so buoyed, and I think while there's a lot to do, not all of it's going to be super difficult. Some of it will be super difficult, and some of it's really easy if we have the will and the impetus. So yes, I absolutely do. And I already feel like we're seeing the results of the changes, the fact that we had, the O&G dedicate a whole issue to miscarriage. I mean, we're really getting and it should be this way because it affects so many people, So, yeah, I do. I feel positive, but just sometimes very, very slightly overwhelmed. Yes.
Can I just jump in with, though, it's so long overdue.
Yeah, it is.
The positioning of women as having to remain silent and endure, there must be sort of this surge of, decades of women's business
totally
just being held back.
And I think one of the things that keeps me going is because all the work that I do is on a voluntary basis until the EPLC gets some funding behind us, which at the moment, believe it or not, isn't our primary priority, but eventually we hope to give it a bit more resourcing. But at the moment, when I do media, when I'm speaking out, when I'm giving keynotes, that's all on my own time and because I want to do it and I'm passionate about it. But what happens is I get so many people contacting me and saying this was my terrible experience. And, while it's very difficult to process some of that, it's also just gives you the energy to keep going because you're like, these are the people that we're helping and these are the people whose kids, I hope, will not have to travel the same road that some of us have.
Thanks, Izzy. The guideline reflects feedback that we receive both from clinicians and patients encouraging a shift away from terms like spontaneous abortion, like products of conception, in favour of perhaps more sensitive terms, miscarriage, early pregnancy loss. While it's best to always ask what language feels right for each person, we also recognise that as clinicians we're constantly learning. hopefully we're constantly learning, and we won't always get it right. Izzy, can you give us your insight on why language is so important?
Language is so powerful. We know this. Like, I'm a writer, I'm a journalist. Like, language is powerful. And when someone, not everyone who has miscarriage experiences grief, but a large number do. And when someone is grieving and you compound their grief, minimise their grief, dismiss their grief with the wrong choice of language, it makes everything worse. And it's such a simple thing to give someone empathy and kindness and recognise that if they recognise that pregnancy as a baby, then what harm does, it doesn't cost you anything to also recognise that pregnancy as a baby, right? And so it's interesting because I've had clinicians say to me, I would never use the term spontaneous abortion in front of a patient. But the problem is that when that's what you're taught in your medical lecture, like if that's the language, inevitably it leaks into the patient-centric. Because the clinicians are often tired, they're overworked, they're in a system that's not fit for purpose. It's gonna be understandable that will happen, but it's incredibly painful for the patient. We see abortion, not that there is anything wrong with abortion, but it is a very different situation to someone who's having a miscarriage.
The impact of that terminology is more profound.
Completely. And if you see your pregnancy as a baby and your doctor refers to it as products of conception, that is a real slap in the face. That is, what are you saying? Like, this is my baby. Like, this is my child, So it just can be extraordinarily painful when that. I know one patient I spoke to who had a loss and it was an ectopic, and the doctor said, so we're just going to put gas in your abdomen to do a expression. It'll be like you're 40 weeks pregnant. It'll just be, and it's like, why would you choose that language? Like, why would you choose that language? And yes, this person, he was not a bad person. He was probably an amazing doctor. This is 10, 15 years later, and she's still crying and traumatised telling me about this, Language is really, really important.
It clearly is. And Nicole, you're an emergency physician, you work in a general emergency department, you're kind of removed from the typical specialist women's health setting that we work in. What tips can you give us about language in emergency departments?
So I speak really from the experience and the observation I've had over many years, and I've even learnt stuff from Izzy even in this podcast. And so we're all learning. The first thing that I would say is one of the biggest challenges is in the emergency setting, we have to acknowledge uncertainty. So there is often, we don't know even if a person is pregnant or not. We find out they're pregnant. We don't know what the trajectory will be. I can't tell people if they're miscarrying or not. So there's a lot of uncertainty. So I'm often very careful to upfront say, I know you want to know what's going on. I'm probably not going to be able to tell you that today. So just clarifying, look, I'm not going to have maybe the answers you want, but I think that's important to establish so that then I can share. The way I think about it is I'm very careful about what I say. I walk in and think, say less and know what I'm saying. So what I'm certain about, I will share clearly with the patient, whether that's about a blood test result or whether it's about an examination or the history. And so I will clarify points I know to be sure. I'll try not to talk too much about what I don't know about. I will talk about possibilities. So this pregnancy may continue, this pregnancy may not progress. And I'm not really sure, but I will usually give a best guess. And if I think this is likely to be a pregnancy that isn't going to progress, I'm not sure that this will go through all the way. This may be a miscarriage. I will say that up front. But there's quite a lot of uncertainty, and then I'll talk through the next steps. I often think in the emergency setting, or when people first contact the healthcare service, they're often in pain, they can have nausea, they're really scared. Not just about what's going on in their bodies, but even the environment. And so all of that plays into their ability to process cognitively. And so I'm very careful about being very clear, speaking slowly, specifically, and allowing them time to process information. I'll often also acknowledge that with the hormones of pregnancy, the ability to think can be quite sort of up and down. There can be emotional lability. You know, they can be sort of up and down and excited and sad all at once. And it's really hard to process all of that. And I'll often name that as well to give them permission to then walk away and go, what did she say? So it's really having put myself much more so into the position of the patient and how they're processing things at the time. And my final thought is always, I try and think for the patient because they're maybe not able to think very well, right? And then be very clear and specific about what the next steps might be. Okay, from here, this is what we're going to do. And then talk through that. And part of that now is the guidelines that we've developed allow me to be able to provide a whole lot more information to patients about what the future options might be with some certainty. I used to actually have to say, look, it depends a bit on who's on as to what the next steps will be, whereas now I can say, look, there are some options which we'll get into in a minute, all of which have validity, and giving them some certainty or some known things in such an unknown circumstance, I think really helps patients, and providing the knowledge of, from the guidelines that we've developed, these are going to be some options, and they'll talk through those at the next stage of the journey. But at least giving people an insight into the next step, I think gives people, correct me if I'm wrong, Izzy, but it gives people at least something to navigate with.
Totally.
Rather than the overwhelm of what's going to happen. Yeah.
And the part of the government package is also an update to the printed guidance that can be given to patients as well to take away with them, because that is a real, what you talked about in terms of not being able to take in information is a real thing. Like, you are panicked, you're freaking out, you don't know what's going on. You know, if there's grief involved, you're like, am I losing my baby? And when a clinician is talking to you, it's just going whoosh. So that is so important. It's a really good point.
There's physiological elements to that as well as emotional and social as well. So it's really complicated.
Yep.
So, yeah, my big tip would be slow down and speak slowly and just take it one step at a time, in dealing with this and taking the time.
Obviously, in an ED world, triage, you're going to have someone with a gunshot to the chest, they're going to take priority and whatever. Just because someone who's having a miscarriage isn't necessarily at the top of your triage list, don't ever forget that that's probably the worst day of their life thus far. So just remember that sometimes patient care is not all about your triage list, is what I would add as well. Like, what isn't life-threatening to you as a clinician, it's a different thing for the patient. So, yeah.
Yep, personally, miscarriage for me is I often will say, I'll see that one. Just because I think I can do a better job. Yeah. Knowing that, and clinicians still have an awfully long way to go, and I acknowledge that really it isn't done very well, probably in the emergency care service sector. I acknowledge that. I'm not going to deny that.
But we're working on it.
Yes. Well, that's why we're here.
That's it.
Being able to reduce uncertainty is really, really an important role that we have. And Kasia, let's talk about that. So our guideline helps to reduce some of that uncertainty. Let's talk about what the guideline says about managing incomplete or miscarriage. The guideline recommends offering women choice. Can you talk about what that choice looks like on the floor?
Thanks, Scott. So the approach that we took in this guideline was to consider both the efficacy and the safety of each of the management options individually and also against each other. And we did that by a process of something called a network meta-analysis. And I do encourage listeners to delve into the evidence summary in the guideline for the details of that network meta-analysis. But fundamentally, each option comes down to having its pros and cons, which as clinicians, we're all very used to that concept. And the idea, again, is to be individualising care to both a patient's preferences and their setting. For instance, in my setting, I see patients who would choose surgical management because for them, they simply can't see a way to be supported to have medical management in a remote community because there isn't staff there who can do that. But at the same time, they can't be away from home and their responsibilities at home for more than a day or two. And so it comes down to patient preference as much as what's available for them logistically. And I think in this moment, it's important to flag here that there's been a big change in the recommendations around medical management, and that's a move away from using misoprostol alone, which for many of us who went through training, that would have been all we would have been taught. The new guidelines recommend using mifepristone 200 milligrams orally, and then prescribing misoprostol to be given 24 to 48 hours later, and that's at a dose of 800 micrograms vaginally or 600 micrograms sublingually or buccally. For incomplete miscarriage, the guidelines continue to recommend using misoprostol alone. And in the cases of both missed and incomplete miscarriage, the recommendation is to consider repeat doses of misoprostol.
That's a really useful practical guidance, isn't it, to try and improve the success rates of medical management of miscarriage. Nicole, what do you have to add?
What stood out for me in developing the guidelines and what came out of it was that all the options, so expectant management, so just letting nature take its course, medical management where there's medication given, or surgical management where there's curettage and stuff, all actually have equivalency. There is none that is one way ahead of the other. And so all have some validity. Yeah, and as Kasia spoke to, it really is dependent on the specific circumstances for that person at that time. I work in rural settings. Getting an ultrasound is in fact a challenge, let alone availability of obstetrics and surgical options. And so being able to say to a woman who is 1,000 kilometres from a regional centre where there may be an obstetric and gynaecology service, saying, it's not my decision, you'll talk about it with O&G, but there's a good chance we might be able to manage this locally and you can stay with your family. There's some risk with that, but there's some benefits as well. And giving women the autonomy in conjunction with the clinician to decide in their circumstance what's best for them is really important. And so for regional, we kind of had to back and forth quite a bit in the guideline development about, but hang on, what does this mean if you're not in a city? And so we very much made sure that the guidelines really only highlighted evidence that was strong, and there's some moderate and weak evidence as well, so that people in different circumstances could make great decisions and understand the options.
I think the hope is that the guideline really empowers clinicians to confidently present all of the options, knowing that there is good and bad aspects of all of them, and really take a patient-centred approach to finding something that will be appropriate and reasonable for that individual at that particular moment in time. And that may be different from one pregnancy to the next. Priorities will change and other factors will come into it.
It's very clear that the different options, and one's not clearly superior than the others, and that it's very much comes down to individual, consumer preference. And I think saying what was right in one pregnancy is not necessarily right in the next pregnancy is a really important observation.
Yeah. And in sort of going over the guideline in preparation for this podcast today, I actually read through some of the evidence. And so there is evidence that the surgical management has a greater rate of certainty around completing the miscarriage. So that's important to know. It's not in the recommendation. But there's some downsides to that depending on your circumstance and setting. So it is, there is value even in an emergency doc who just wants to know what's the plan. It's a bit deeper behind just the recommendations if people have time to have a look at it.
Yeah, Izzy, what do you see as some of the broader issues around medical management of miscarriage nationally, internationally?
So there are some. Basically, the mifepristone misoprostol combination is not on label for miscarriage treatment. So what we know is that using one medication, which is how it's currently labelled, is less reliable, if I can put it like that, than using the combination. And if you use the combination of both of them, that patient is less likely to have an incomplete miscarriage, which would then require a surgical intervention, although, Freudian slip, it could be a cervical intervention as well, who knows. Anyway, so a surgical intervention. I'm currently working with RANZCOG President-elect Nisha Kott and Dr. Alex Bonner of the Early Pregnancy Network of Australia, and we have been working in conjunction with MSI Australia, formerly Mary Stopes, because the application has to come from them as the medication provider, just to support them in making an application for the change of labelling, and government, the regulators have been very, very receptive. So it's more a question of ticking all the boxes and working on the application. But we do hope to see that change, because it's just a no-brainer, and it's a sort of leftover loophole from when two-step was introduced, and there were far too many barriers put in place around it. And we've seen other ways in which those barriers are being broken down for use of two-step in other applications. So the only thing I would kind of add to the, what my friends here have said around choices is that I think doctors need to, from my anecdotal experience, doctors need to be very clear, and this is why the guidelines are so important, what is actually medically provable and what is their personal opinion.
What's the evidence?
Yes, where is the
And
evidence for what you're telling me? And also, I think there is a lot of cases in the system of choiceless choices, which is what, in a reproductive justice sense, is where you tell people they have choices, but then if they say, okay, I'd like a surgical, to end my miscarriage surgically for whatever personal reason, and you say, well, we can't because there's a waiting list of X, Y, and I just don't put you on the list as a high priority. I think you should have a medical management because it would be better for me. That's what we call choiceless choices. So we need to ensure, and I mean this goes for so many different things in the system, that the system's actually fit for purpose in being able to follow through on the choices that patients make.
Kasia, we've been providing surgical management for miscarriage for a long time. What's new in the guideline around surgical management of miscarriage?
The guideline highlights 2 key recommendations, and the first of those is to use suction aspiration instead of sharp curettage, because we know that sharp curettage increases the risk of intrauterine adhesions compared to suction aspiration. We know that risk also rises with further miscarriages and evacuation procedures, so it's a perhaps even more important consideration for people who have recurrent miscarriage and are facing this situation again. The second recommendation that I think is important to flag, because it is a change in practice from many of the state-based guidelines, is antibiotic prophylaxis prior to suction curettage. The types of antibiotics and dosages used across the different trials varied, but probably the most prevalent was single-dose doxycycline, given with or without metronidazole, and given 2 hours prior to the procedure, which is probably achievable and practical in most settings.
Yeah, really important changes in guidance or guidance considerations, aren't they, particularly in reducing the risk of intrauterine adhesions, which have important impacts on future pregnancies.
And fertility,
And fertility, thank you. Lots of the use of progesterone for early pregnancy support, particularly in the miscarriage prevention, has been relatively topical. What's the evidence say about that?
I think actually these recommendations around progesterone in threatened miscarriage are particularly welcome, given there's been historical variation in practice in both Australia and overseas. And I'm sure that many of us have been in situations where we've seen a patient who had progesterone prescribed in a previous pregnancy, and then in the current pregnancy we're uncertain about its benefit and whether it's appropriate to prescribe it again. And this guideline offers 2 strong recommendations on progesterone use in early pregnancy, and the difference between these recommendations is really based on whether there's been bleeding in early pregnancy. And I think that means it's quite easy to use this data well. So for women with recurrent miscarriage who have early pregnancy bleeding, the guidelines do recommend using 400 milligrams of vaginal micronized progesterone twice daily, because there is moderate evidence that improves live birth rates. However, for those patients who have a history of recurrent miscarriage, so 2 or more previous miscarriage, but do not have early pregnancy bleeding, the evidence doesn't support using progesterone in that setting, and so the guideline has not recommended that.
When I wrote my book, I had basically a disagreement between Dame Leslie Regan and Ari Kurumasamy, which I write about in the book. I mean, progesterone is one of the most controversial topics in the miscarriage world because, the guidance from the UK changed halfway through my losses. So I was being told, no, we won't prescribe you progesterone, and then being told, here you go, have some progesterone. I'm like, what's going on? I had medical whiplash. I'm like, what's and this huge study had come out and changed it. But again, like you said, it's marginal. It's not convincing. It's and I think it really comes down to practitioner preference, don't you?
Well, I think the guideline is actually the recommendations are strong.
Yes, absolutely.
And the evidence for these 2 options or these 2 situations and how to prescribe differently in these 2 situations was actually, I think, quite clear.
Yes.
And I think that's such a relief to a clinician to have clarity about if the patient is having bleeding, then yes. If the patient is not having bleeding, then no. And I think that sort of makes it easier to, as we discussed earlier, present to the patient what the evidence shows and be able to say, it's not that I don't want to help you, it's that I don't think that giving you this is going to have any benefit, and I don't want you to put you through the expense, the discomfort,
Totally.
the practical...
And I can confirm it's deeply uncomfortable. So, yes.
the practical
for that.
difficulties
You're welcome. My pleasure.
of doing this. Yeah.
And I'll just throw in, as a practical sort of ED clinician on the Guideline Development Group, and I'm sitting there going, oh, yeah, progesterone, whatever, remember that from med school. But watching the process of the evidence deliberation and the way that it was looked through, the original stuff, I looked at the numbers are at something like 17,000 women were collated to get the initial evidence for based around miscarriage recommendations around management. Smaller numbers for progesterone, but I feel very confident in the process that RANZCOG has undertaken in the way that the evidence has been looked at, so that it's kind of the best that I can see of what we've got. It's not one person's opinion or a particular slant. It's trying to look at the science, as limited as it is, and we'll talk about that in a bit, and sharing what science knows, what the profession knows with women, so that a decision can be made.
Well, I'm going to leap in here and make a plug for the RANZCOG Research and Policy team. Thanks.
Yes.
I'll pass that on to them when I see them again. But what people who've been around our college for a while will notice is that over the last 3 or 4 years, the quality of RANZCOG guidance has really improved. We've shifted away from a process that looks at expert consensus to really a thorough, robust, evidence-based methodology. And in a lot of the stuff that we do, the evidence is lacking. But it's nice where there is clear evidence such as this to be able to provide firm, robust, clear guidance for clinicians, and hopefully that's what our members and our listeners are taking from our guidelines. Let's move on a little bit. Let's move to recurrent miscarriage. The guideline, as an important change, now defines recurrent miscarriage as 2 or more previous pregnancy losses compared to 3 consecutive losses that we traditionally use. Nicole, how's that changed practice?
In my understanding, there's just been variability in the way that it's classified, and it's not so much a change, it's a decision to say recurrent miscarriage is 2 or more pregnancy losses at any time, is kind of my simple understanding of it. To recognise that there is complexity but for the experience from the patient perspective and the families involved, it's the same deal. And there's Kasia will talk into the details of the evidence, but it's to really just open up or broaden the group of women that are included in that. So.
Well, because it was always really the difference between ESHA guideline and the RCOG guideline, and the one saying 3, one saying 2, non-consecutive, consecutive. It made it really, once again, uncertain for clinicians working in early pregnancy clinics, emergency departments, gynaecology units, wherever. But it made it so unclear for us, and the person in front of you would often say, but the last person I saw or someone else I know, and you always sort of felt a bit hamstrung because you didn't have a local clear definition that allowed you to proceed or not proceed with doing investigations. And I think certainly as a more junior clinician, that was even more challenging because you didn't feel that you had the authority to say, well, in this situation, it would be appropriate based on our conversation and this person sitting in front of me to adopt maybe the ESHA guideline in this case and use the RCOG guidance in another situation. And so I think choosing a definition that is pragmatic, it isn't, I think, going to necessarily increase by a huge number the number of abnormalities or investigations we find, because we know that these investigations have a limited amount of evidence behind them, some of them. But it certainly, I think, will have a very significant impact on patients, I imagine. Izzy?
Yeah, I think that, investigations is a very... And education or further information is very broad, right? So it depends on the loss, it depends what gestation that loss was at, it depends on the medical history of the patient, it depends on whether that patient is known to have a translocation or there's all sorts of things that can affect what kinds of investigations a clinician would choose to do in concert with their patient, if I can say it like that. So, but I think definitely from a patient point of view, you're sitting there and you're going, well, I've had 2 losses and you're telling me just go try again? Like, that doesn't sit well. Like, what? Why is this happening? Like, the whys, And it may be a case that, in my case particularly, it was more a case of like ruling out the nasties than it was, giving me a scan, making sure that there was nothing, no physiological issue that would affect implantation, or it was just, again, doing some basic genetic testing, make sure there was no translocation or anything but that wasn't done until very late in the piece. So I would have really rather gone into subsequent pregnancies after my 2 losses with a bit more confidence, knowing that I think it would have helped support me go into subsequent pregnancies, knowing that some of those, what I call the nasties, were excluded from anything. So yeah, but I think the important thing is, like, there are lots of different options within that scope of investigations or information. Yeah.
And it certainly validates your experience of a pregnancy loss when we say you don't have to meet a certain number for us to decide that you've reached the threshold for, okay, you've been through enough.
Yeah.
2's probably enough, and we can probably validate your losses at,
let's
at 1 and 2.
Let's just rule out some nasties so that you have a little bit of confidence. It may be that this takes the form of, okay, well, we're going to do testing on pregnancy tissue if you have another loss. There's all these different options, and it may just be that patient needs support and mental health, psychosocial support from a frontline services provider in that space. So it can take lots of different forms, but certainly I think I'm very, very pleased to see. I mean, the idea, one miscarriage can really destroy a life, as in the life of the birthing parent or their partner or their family. Imagine having 3 or 4 and people, or 3, before anyone actually seems to, in huge inverted commas, take it seriously, and say, maybe we better make sure there's nothing else going on,
And so what I'm hearing from you is the next step is often determining, can I or can't I get pregnant? Like, it's not about why did I miscarry, but is it futile or not? There's just that clarification around that.
Yeah, I think I don't.
And it's not please explain. It's just give me a bit more info.
Yeah, I think this idea that it's sort of just Russian roulette, and you might have a baby and you might not, and it's all just luck, and yes. In a clinical sense, we know that there's a lot of luck involved in getting pregnant and carrying a baby to birth, but the patient mindset is different. It's like, if I've had 2 losses, there's something wrong with me, right? So they want the clinician to be able to say to them, is there something wrong with me? If there is, tell me what that thing is. And we know that's not always possible, right? But certainly there are obvious things that we can rule out. There are very obvious things that we can say, you don't have antiphospholipid, you don't have a clotting disorder, you don't have Hashimoto's, you don't have, a misshapen uterus that might affect, that's a whole different kettle of fish, because some people don't believe that affects miscarriage. But hypothetically, if a clinician did do a test, see if they've got not non-conventionally shaped uterus. Like, there are all these things, or a translocation or anything else. So there are things that you can knock out, but yes, it's always the why. And I think asking a patient to go through that and just telling them, no, just go home and try again. And it's like just what? Like, we're not going to acknowledge that there could be potentially an issue here. You just want me to do it again and just keep doing it till it sticks, It's just not in keeping with the way a patient brain works, I don't think, It feels like, I think that element of luck is very difficult for a patient to get their head around. And that's why you see miscarriage patients are often susceptible to misinformation or alternative therapies, because we're just looking to do something different to maybe have a different outcome.
So we've started to to hint at some of the investigations that we might do for a woman who's having recurrent miscarriages. Kasia, what does the guideline say on that?
So once again, this is a space in the guideline that I think there's really helpful table. It is table 1 in the guideline, and it summarises the tests that we suggest can be routinely recommended, those that may be considered on a case-by-case basis, and those tests that are in fact not routinely recommended, and that's based on the levels of evidence around those investigations. To summarise, lupus anticoagulant, anticardiolipin antibodies and testing for thyroid disorders, as well as 3D ultrasound, are really the only tests that the guideline suggests should be routinely recommended in the investigation of recurrent miscarriage, so 2 or more miscarriages. Having said that, there is another part to this answer, which is that we included a good practice point that highlights that this has to be a pragmatic approach, and there are going to be situations where it's really important to discuss and individualise whether to even do these investigations, acknowledging that there may be benefits but also harms of knowing the outcomes of testing, and that not all tests are going to be appropriate in all situations, settings and for all individuals.
I'll just add, I think a lot of deliberation went into the table. I remember listening to all of that with a lot of the test names going over my head. But it was also trying to navigate for patients who are not in cities, who don't have ready access to some of these tests. And so have we got evidence to say effort should be made to allow these? Or these are the options. So again, weighing up that benefit risk rate,
And all of these
aspect.
tests that we have recommended should be routinely available in all settings. Apart from 3D, good quality 3D ultrasound, I think most people, even in a rural area, will be able to get those blood tests. And I suppose it's more about also thinking about what tests might just be best in a research setting or might need more work to determine their efficacy. And that table creates a nice reference point for going to the things. And I think it's something that people could use with their patients to look at together and say, I'm recommending these tests. This is why. These are the guidelines. This is the recommendation. Yes, these other tests are things that we could discuss, but there are reasons why we may or may not want to do those tests in the first instance. And that may be something we come back to at a later date. And I think that's, again, appropriate to have something that's a tool you can use with patients to discuss, as we've talked about before, the evidence behind why we're recommending what we're recommending, and to be very clear and transparent with people about our choices.
Kasia, the guideline also highlights emotional support and the provision of emotional support. How can clinicians guide that, especially when they're in time-poor settings where resources are stretched?
We've talked about this a little bit already, and I think it's the acknowledgement of the situation and the difficulty and the predicament and the emotional burden that this person has in front of you has found themselves in. So acknowledging the loss, even if it's 6 weeks, even if it's 12 weeks, acknowledging that the person in front of you is experiencing something that, as Izzy put it before, may be the worst day in their life. Be clear in the information that you provide, and be clear about the evidence behind it. Provide written resources and referrals on if you feel like someone's going to need more than you're able to provide them in your setting or within your service. For patients who are coming in through places other than a dedicated early pregnancy unit, and I think particularly somewhere like an emergency department. Certainly from patients we've had feedback about things like privacy and quiet spaces, and they're often difficult to negotiate in busy emergency departments.
But so important.
And they can even be often difficult to negotiate in a public hospital waiting room where there may be concurrent clinics running, or in an ultrasound waiting room where there will be pregnant people and non-pregnant people and miscarrying people in the same space. So, and I think also involving partners or support people, and there are great resources out there which are directed towards partners and support people, and I think it's really worth thinking about who else in this space needs support apart from the individual who's losing the pregnancy. Izzy, when we were preparing this session, was talking a bit about the pregnancy, subsequent pregnancy after a loss, and I think that's a really important factor, and it's often a question people do ask: when can I try for my next pregnancy? And the sort of physiological, practical approach is, probably wait 1 to 2 cycles, make sure that all the bleeding's settled down and everything's normal, and then go ahead. From the emotional perspective, it's probably a very more profound question of whenever you feel ready. And that will be a elastic amount of time from one person to the next, and from perhaps one pregnancy loss to the next. These are things that I think we all aspire to and we would love to provide. And you talk about resource limitations and a system that's fit for purpose. And I suppose it's making the best of the system you work within and trying to provide as good an individual experience for each person as you possibly can, and learn and reflect from each time whether there's things you could have done differently or better, and evolve as a clinician in that regard.
The only thing I'd add to that is obviously like pregnancy after loss as well. You spoke a bit about that, but where there is a pregnant subsequent pregnancy, where that patient has decided to become or has become pregnant again, there needs to be support given to that patient. Pregnancy after loss can be very, very challenging for some patients, and I think a little bit more empathy in that regard would not just be beneficial to them psychologically, but actually there is evidence out of the UK that can actually help with outcomes. So, it's all of our business, I think, to be empathetic and caring. Yeah.
And I'll just add for clinicians out there that this is sort of difficult and overwhelming. They don't know a lot about this space and they're dealing with it. Just acknowledging the distress and how difficult it is for patients alone will get you a long way. Just acknowledging that and taking it from there.
Yeah. Kasia, you've spent a lot of time with your group. You chaired this group, reviewing the evidence around miscarriage and investigations and treatment and management strategies. And what do you see as the future state of this field of research and for the care that it drives?
So we have to acknowledge that there were low levels of evidence for some aspects of our care that we considered in this guideline, and they really pointed to our gaps in our knowledge, or obvious gaps in our knowledge. And so in the guideline, we have listed some recommendations for future research, and we propose that there needed to be more done to investigate many things, but briefly, where care is provided, by who, women's experiences and their experiences of using services. Further research into many aspects of management of miscarriage, which includes things that seem quite basic, like analgesia, but also women's experiences, and particularly in the cohort of women experiencing later pregnancy loss, which is a cohort there's not as much data in. The interplay between endometriosis and early pregnancy was something we noted was visibly limited in terms of the data available. The incidence, impact and treatment options for intrauterine adhesions, the diagnosis of subclinical hypothyroidism, and then also further study into the roles of various tests for recurrent miscarriage, which include ANA and DNA, sperm DNA fragmentation and beta-2 glycoprotein antibodies.
Izzy, where do you and your contemporaries need us to go?
It's interesting, just on the topic of sperm DNA fragmentation. I had 7 losses across my reproductive journey, and do you know how many times my husband's sperm was tested? None. And every single piece of research shows that it's bizarre. Like, it takes an egg and sperm, right, to make a baby.
Yeah.
It's like, who would have thought that maybe that would have been something to think about? Anyway, sorry. Look, I think obviously medical research is so badly lacking in all the areas that Kasia said, and we do have more research on the psychosocial side, but we want to see a tissue bank. We want to see much more investigation into minority groups who, like Aboriginal and Torres Strait Islander people and newly arrived migrants, people that don't speak English. We want to know, and that the data that's now we're supporting a scoping study to collect miscarriage data, which is being run by the AHW, but we're supporting that and we asked for it in the budget. So that will also inform where further research is necessary. But there's just so much to be done. The list is very long. That's why the EPLC is looking at doing a national miscarriage roadmap in a similar way to what was done in the stillbirth area, so that we can really sit down with clinicians, medical researchers, midwives, nurses, all of and psychologists and all of the people, and of course lived experience, who work across the breadth of touch points and figure out a list of priorities and in what order they need to be done. So.
And I'll just add that there was very limited evidence around rural, regional and remote experience in all of the data that the Guideline Group looked at.
Before we wrap up, Nicole, Kasia, Izzy, what's one key takeaway that you'd like to leave our listeners with? Kasia.
It's great to have a guideline that has summarised the evidence, and it's a great reference. But as we all know, evidence-based care goes hand in hand with empathy and pragmatism and the need to be adaptable and responsive in our approach to ensure best care for the person in front of us in the location in which we're practicing. And I'm going to take a moment to also flag that this is a great opportunity to encourage fellows and trainees to participate in guideline development groups. There are many topics coming up, and the college does advertise what is going to be reviewed next. It's a really fantastic way to be involved in a systematic review of the evidence, to expand your thinking on these topics and earn CPD points at the same time.
My takeaway would be take time to honour the privilege of the communication required at that point of contact with a person experiencing early pregnancy loss or uncertainty in their pregnancy. Take some time to do that as best you can and to really understand or at least appreciate the complexity for the patient in that moment. Be kind on yourself. You get better with it every time.
It took me like 3 years to write my book, 1 year full time out of that, and 7 losses to be informed enough as a patient about what questions patients might have and also what questions clinicians might have. And I hear a lot of buzzwords. I heard a lot of buzzwords in that time. I heard words like holistic patient care and patient-centric care and all of these sorts of things. And sometimes they're great in theory, but they're not put into practice. The patient has the right to make choices that are deliverable, or that are delivered. And the patient has a right to ask whatever questions they want to ask so they understand what's happening to their body and why decisions are being made or whatever else. And I really want to see more of that. And the final word I would give is that while I am a writer and a journalist, the words that I love most about this area actually come from the Lancet, and it is that the time to tell people to just go home and try again is over.
On that, it's a great way to sum up. I'd like to thank our guests, Dr. Kasia Siwicki, Dr. Nicole Liesis and Izzy Oderberg. This episode was built around the new RANZCOG guideline on miscarriage, recurrent miscarriage and ectopic pregnancy. You'll find the link in our show notes or on RANZCOG's website under guidelines. For more resources, visit the RANZCOG website, Miscarriage Australia or the Early Pregnancy Loss Coalition. We'll be back soon with more, exploring the clinical issues, guidelines and research that matter most to our members. If you enjoyed this podcast, please rate, review and subscribe and share it with a colleague. It all helps. And remember to log this episode for continuing professional development.